All right, good evening, guys. Welcome to tonight's review. Tonight we're going to talk about pathology. So let's begin so that we can make progress. Okay, cerebrovascular disease, stroke. What is it? So it is the third most common cause of death in the United States. It is the leading cause of neurological disability. Question, two types of stroke, ischemic stroke and hemorrhagic stroke. Out of those two, which one has an increased incidence in the United States? Ischemic or hemorrhagic?
Ischemic.
Ischemic, excellent. So like approximately more than 85% of cases in the US, you have ischemic strokes. How do we classify them? Reversible ischemic neurological deficit, evolving stroke, and completed stroke. However, your level, you need to understand TIA, transient ischemic attack. What is this? So it is a neurological deficit that lasts from a few minutes to no more than 24 hours, but usually less than 30 minutes. So what is a distinguishing feature? The duration of symptoms. It lasts from a few minutes, no more than 24 hours, but lasts less than 30 minutes. There are transient. Why? Because reperfusion occurs either because you have a collateral circulation or of the there's a breaking up of your embolus. Remember, the blockade in the blood flow does not last long enough to cause permanent infarction. So a TIA is usually embolic, right? High yield. Once a patient has a TIA, there is a high risk of stroke. The risk is increased within days of the TIA, and then the risk of stroke at 30 days and 5 years is like more than 10% and 30%. How are we going to evaluate after the patient has TIA, high yield? You need to do brain neurovascular imaging, your MRI, ECG, and cardiac monitoring. Sometimes you can also do like inpatient telemetry or echocardiogram and laboratory. High yield. The most important risk factors are age and hypertension. Others are secondary: smoking, diabetes, hyperlipidemia, AFib, CAD, family history of stroke. In younger patients, the risk factors are OCP use, hypercoagulable state, protein C and protein S deficiencies, antiphospholipid antibody syndrome, also vasoconstrictive drug use like cocaine, methamphetamines, right? Polycythemia vera, and sickle cell disease. When you go to clinicals next year, hopefully, you're gonna learn about the ABCD score. This is like a risk stratification tool to identify patients at highest risk of early stroke. So ABCD is a mnemonic. It stands for age, blood pressure, shortly after TIA, clinical features of stroke, duration of TIA symptoms, and diabetes, right? Okay, maybe this is for step 2, but TIAs can involve either the carotid or the vertebrobasilar system. The carotid system or the vertebrobasilar system. How are we going to differentiate, doctors, between the two? If the carotid system is affected, what can we see in a patient? If there's an occlusion on your carotid artery, what can we see? We can see temporary loss of speech. We can see like paralysis, paresthesia, and this is classic. Have you ever heard of amaurosis fugax? Yes or no?
No.
No? So this is an example of TIA. In the vignette, they're going to describe, doctor, I can't see on my left eye. It looks like a curtain is being drawn down. That's how the patient is going to describe it. So that's amaurosis fugax. It's an example of a transient ischemic attack. What is this? It's transient, of course, and you have a curtain-like loss of sight, an ipsilateral eye. Due to what? There's a microemboli to the retinal artery. That's an example of the carotid system is involved. How about the vertebrobasilar system? From that word alone, vertebral and the basilar system. What can we expect? Signs and symptoms in the patient.
Maybe locked-in syndrome. I know, like basal artery.
Okay, so you can have like think about dizziness, double vision, vertigo, cranial nerve, numbness. You can have ipsilateral face, contralateral limbs. You can have hoarseness, cranial nerve 10, dysarthria. You have dysphagia. You have projectile vomiting, right? So high yield point here, carotid system. Think about that curtain-like loss of sight in ipsilateral eye. Amaurosis fugax. That's an example of TIA. So what are the causes then of TIA? Emboli, right? Origins where? Number one, the most common high yield, the heart. There's a mural thrombus in patients with AFib. The most common site of mural thrombus formation. Where is it? What appendage? High yield left atrial appendage. That's the most common site in AFib. Also, the internal carotid artery, right? Sometimes the aorta. Now, there's a term called paradoxical. What do we mean by paradoxical? It's an emboli arising from blood clots in the peripheral veins that passes through a septal defect. So when your patient has a congenital heart disease, for example, ASD, or a patent foramen ovale, or pulmonary AV fistula, this embolus travels and it reaches the brain, okay? High yield paradoxical emboli, blood clot from peripheral veins. How does it pass through the arterial system? Because of what? Septal defect. ASD, PFO, or a pulmonary AV fistula. Now, remember the causes of stroke. Can you give me three causes of stroke? Due to what? How can someone have stroke?
An occlusion.
An occlusion, okay. So remember ischemia due to atherosclerosis. What else? AFib with clot emboli to the brain. And you can have, remember the endocarditis? Septic emboli from endocarditis. So ischemia due to atherosclerosis, AFib with clot emboli to the brain, and septic emboli from endocarditis. How about thrombotic stroke? These are atherosclerotic plaques that may be in the large arteries of the neck or in medium-sized arteries. Question, how are we going to evaluate a thrombotic stroke? Remember, these are plaques from large arteries of the neck, right? Most commonly from the bifurcation of your common carotid artery. Or in MCA, middle cerebral. So my question is, how are we going to evaluate the source of an embolic stroke? You could do Doppler imaging. You could just do that. You could do vascular imaging. You could do EKG, of course. You can do cardiac monitoring and echocardiogram. Now, contrast thrombotic stroke with lacunar stroke. Lacunar stroke, what's the key word here? Small vessel thrombotic disease, right? What's the predisposing factor? High yield hypertension. Hypertension. Another important factor is diabetes. But if two of them are in the answer choices, pick hypertension, because that is present in 80 to 90% of lacunar infarctions. There is narrowing of the arterial lumen due to thickening of the vessel wall. This is not by thrombosis. The lacunar stroke is not by thrombosis. You have a thickening of the vessel wall. Where can we see the affected arteries? The small branches of your MCA, and of course, the arteries that make up the circle of Willis. Can you tell me the arteries in your circle of Willis? What are they? ACA, MCA, PCA, right? You have anterior communicating, posterior communicating. So when these small vessels occlude, small infarcts result. And when they heal, they are called lacunes. Now, what are the clinical features, right? Before that, You also have non-vascular causes of stroke. For example, if you have a low cardiac output, like shock, or congestive heart failure, right? And anoxia, which can cause global ischemia and infarction. So, the etiology of stroke in a nutshell. We have stroke, right? Hemorrhagic and ischemic stroke. Hemorrhagic stroke, mainly intraparenchymal or subarachnoid. In ischemic stroke, you have different kinds. Maybe it is due to atherosclerotic cardiovascular disease. Maybe it's through the lacunar stroke, or there is cardiogenic embolism due to AFib, valve disease, ventricular thrombi, many others, or some other unusual causes. Dissection, aortic dissection, arteritis, also like migraine, vasospasm, drug abuse, and prothrombic states. If you have like protein CNS deficiency or antiphospholipid syndrome. So what are the clinical features of a stroke? Thrombotic stroke, high yield. The patient awakens from sleep with the neurologic deficit. Okay, that's thrombotic. Embolic stroke, the onset is very rapid, within seconds. And they're going to say that in the vignette. And the deficits are maximal initially. So clinical features depend on the artery that is occluded. What is the most commonly affected artery? The MCA. So if you have an MCA involvement, what happens? High yield from term 2. You have contralateral, opposite side, hemiparesis and hemisensory loss, aphasia if the left hemisphere is involved for 90% of population, and apraxia, or contralateral body neglect or confusion if the non-dominant hemisphere is involved. Point here, for embolic stroke, you have contralateral body neglect only if the right hemisphere is involved. Thrombotic stroke, the patient awakens from sleep with the neurologic deficits, right? Embolic stroke, rapid onset, MCA artery is the most commonly affected. I have a question for you guys. I don't know if you heard about this one. Subclavian steal syndrome. Does anyone know this? Subclavian, did you talk about subclavian steal syndrome?
Is it like shunting? I don't think we covered it, but I think it's like shunting.
Good job, good job. Can someone explain to me the pathophys of subclavian steal syndrome? So you have a stenosis of the subclavian artery, proximal or distal to the origin of the vertebral artery? Closer or away? Proximal or distal? Proximal, excellent, excellent. Proximal to the origin of the vertebral artery. So you exercise the left arm. What happens? If you exercise the left arm, it causes reversal of blood flow down the ipsilateral vertebral artery to fill your subclavian artery, distal to the stenosis. Why? Because it cannot supply adequate blood to the left arm. So what happens now? Because of that, it leads to decreased cerebral blood flow. So in layman's terms, blood is stolen, quote unquote, from the basilar system. So it causes symptoms of vertebro-basilar arterial insufficiency. So the blood pressure in the left arm is less than in the right. You also have a decrease in pulse in the left arm. How are we going to treat subclavian steal syndrome? You just do a bypass surgery, a surgical bypass. You also have some upper extremity claudication for that. Excellent, guys. Now, lacunar stroke, again from term 2, high yield, pure motor lacunar stroke. If the lesion is involving the internal capsule, pure sensory, if lesion involves the thalamus. Motor, internal capsule. Why? What goes into the internal capsule? Your corticospinal tracts, right? Sensory, thalamus. The others are, don't bother about that. Okay. So if you have Initial assessment. How are you going to assess a patient that has a stroke? Of course, history, neurological exam. You do CT scan of the head without contrast. That's high yield. Initial management. Okay, that's the key word. Initial management. And then you do MRI of the brain. That's the answer if the question is asking most sensitive test, okay, for stroke. You pick MRI of the brain. If it says initial test to do, it's CT scan of the head without contrast. So make sure you read the question carefully. You could also do an ECG, and you can also have some labs. So we use CT scan of the head in the emergency department to differentiate, of course, ischemic from hemorrhagic infarction. Also, it identifies like abscess, your tumor, and high yield. Don't forget, it also identifies subdural or epidural hematoma. Okay, and now let's go back to term 2, guys. Deficits seen in stroke. If there is an infarction in the anterior cerebral artery, tell me the location and type of deficiency. Anterior cerebral artery. Where is the deficit? High yield.
The legs, right? Like lower limb.
Yes, excellent. Contralateral or ipsilateral. That's important.
Contralateral.
Contralateral, excellent. So anterior cerebral artery, it causes contralateral lower extremity. And don't forget the face, of course. How about MCA? What can we see if the MCA is involved? Aphasia, right? Aphasia, it's in what kind of aphasia? Broca's or Wernicke's? Guys, where can we, is it Broca's or Wernicke's?
Is it both?
MCA.
Is it Broca's?
It can be both, but if it's left hemisphere, right, the dominant left frontal lobe, it's the Broca's area. Where can we find this one? What gyrus? What gyrus is the Broca's area?
Central, I think.
What?
Post central.
No. What gyrus in the frontal lobe? Inferior frontal gyrus. Remember, you have the inferior frontal gyrus, and then your superior temporal gyrus is your Wernicke's area. Okay, don't forget that from term 2. So for MCA, you have aphasia and contralateral hemiparesis. Now, how about, as I've said, vertebral system or the basilar system? You have ipsilateral ataxia. Someone says diplopia, that's good. Dysphagia, dysarthria, and vertigo, right? How about PCA lesions? People, let's go back to term 2. PCA lesions, posterior cerebral artery. What can we see? Give me that classic thing that we can see in a patient for PCA lesions.
Down and out, the cranial 3.
Posterior cerebral artery lesions.
The bitemporal hemianopia.
Exactly. Homonymous hemianopsia, of course. If there's a sparing, then you have a macular sparing, right? So for lacunar, don't forget internal capsule, motor, thalamus, sensory. Okay. All right. So we have that one. We can check the labs. What are the complications though? So for initial assessment, history, neurologic exam. What's the first initial step? High yield. CT scan of the head without contrast. What's the most sensitive test in detecting stroke? MRI of the brain. Can we do ECG? Yes. Why? It can detect acute MI or AFib, which is one of the etiologies of stroke. You can also do basic metabolic panel, CBC, electrolytes, your creatinines, and all of the others. So what are the complications of stroke? progression of neurologic insult. Remember, cerebral edema occurs within 1 to 2 days. It can cause a mass effect for up to 10 days. So what are you going to give, doctors? You can give mannitol to lower the intracranial pressure. Of course, sometimes you have hemorrhage into the infarction, and you can also have seizures. If someone is in epileptic seizure, how are we going to manage them? What's the first medication that we can give, doctors, for seizures?
Valproate.
Valproate.
Valproate. And then for seizures, for what's the management for seizures?
The benzodiazepine first?
Benzodiazepines, right? And then after that, you can give valproic acid. If it doesn't work, what's next? Phenobarbital. Phenobarbital. If phenobarb doesn't work, what's next? Well, last resort actually is like propofol and those anesthetics. Okay. How are we going to treat them? Stroke. So if it's acute, of course, remember ABCs: airway, breathing, circulation, high yield, TPA. But you only need to administer TPA within 4.5 hours. Read the vignette carefully. If it's more than that, you can't do TPA. You do percutaneous, okay, coronary angiography. Do not give TPA if the time of stroke is unknown, high yield. Okay, if you don't know the time in the vignette, they didn't specify the time, then you shouldn't give TPA. Question: do you give streptokinase or alteplase for your TPA, and why? Why do you pick one than the other? Why one is much more effective than the other? For thrombolytic therapy, let's go back to cardiac. Anyone?
I think it's like alteplase, but I don't know why.
Yes, of course, alteplase, but why?
The shorter, faster acting.
Why not streptokinase? It's the same thing.
Is it because?
Do you want to reactivate old infarcts? That's why. You don't want to do that. You don't want to clog like the old infarction, to bleed again. Okay, that's why streptokinase is rarely used. We actually use alteplase, right? However, guys, even though you give alteplase, any thrombolytic therapy, there is a risk for intracranial hemorrhage. Therefore, you don't give aspirin for the first 24 hours. You always perform neurological check every hour, and you need to carefully monitor their blood pressure. So, aspirin should be given as early as possible, unless TPA is used, right? Ideally within 48 hours of stroke onset. Can we give anticoagulants? They have not been proven to have efficacy in acute stroke. However, we give them when they are hospitalized for DVT or VTE prophylaxis. In terms of blood pressure control, you need to control it if the patient is receiving TPA. Why? To reduce the likelihood of bleeding. So, high yield. If stroke is caused by an emboli from a cardiac source, you need anticoagulation. Treatment of strokes is like prophylactic. Once a stroke has occurred, there is nothing that can be done to salvage the dead brain tissue. That's the point. The goal, however, is to prevent ischemic events in the future. Once your brain, part of the brain is dead, we can no longer do anything about it. So our goal now is to prevent that thing that will gonna happen again in the future. We need to prevent the ischemic events. How are we going to prevent that? First, you tell the patient, lifestyle and pharmacotherapy. Stop smoking, sir, ma'am, right? Stop eating too much. If they're obese, lose weight, go to the gym, okay? You give them also aspirin, right? long-term antiplatelet therapy. You give high-intensity statins like atorvastatin, rosuvastatin. You can also do surgery for strokes due to carotid artery disease. In symptomatic patients, they said the carotid endarterectomy, right, with carotid artery stenosis of more than 70% is effective. In asymptomatic patients, like carotid endarterectomy is not indicated. So in other words, the high yield point here is this. If the carotid stenosis is more than 70% and the patient is symptomatic, then you can give them carotid endarterectomy. But if the patient is asymptomatic and the carotid stenosis is less than 70%, do not perform carotid endarterectomy. All right, let's go to intracerebral hemorrhages. It has a high mortality rate, guys. There's significant morbidity. Hematoma formation and enlargement may lead to what? Local injury and increase in intracerebral pressure. Question: two major categories of hemorrhagic stroke. You can have intracerebral hemorrhage, which is a bleeding into the brain and parenchyma, and you can also have bleeding into the CSF outside of the brain parenchyma. High yield. What's the cost? Etiology. Hypertension, right? A sudden increase in blood pressure is the most common cause. Pick that one. That's the correct answer. Hypertension. Why? It causes a rupture of small vessels deep within the brain parenchyma. You call this one your lenticulostriate arteries, which is a branch of your middle cerebral artery from term 2. So chronic hypertension, it causes degeneration of your small arteries, leading to microaneurysms. So ischemic stroke may convert to a hemorrhagic stroke. I don't know if you know this, guys. Trivia for you. This is one of the main causes of stroke in young patients. Trivia.
Cocaine use?
Excellent. Good job. Who said that? You're right. Cocaine is one of the main causes of stroke in young patients. Okay. Don't forget, hemorrhages, whether it's intracerebral or bleeding into the CSF, they are all, and ischemic stroke, they are all associated with cocaine use. Think about it. Why? Because cocaine is a potent vasoconstrictor, right? Most common location of stroke, pick basal ganglia, 66%. The basal ganglia is involved. So what are the clinical features? Abrupt onset of a neurologic deficit, altered level of consciousness, headache, and signs of increased ICP. All right, guys, question time. What can we find in the pupils? You check, right? If you're doing your OSCE, you're checking the pupil. What are the pupillary findings in intracerebral hemorrhage? If there is a pinpoint pupil, what part of the brain is affected? Pinpoint pupil. P, think pons.
Pons.
P, pinpoint, think pons. So P and P, okay? Next, poorly reactive pupils. Think thalamus. If you have like a dilated pupils, think the putamen, okay? Just like, I don't know, it's like a fact. So how are we going to diagnose intracerebral hemorrhage? CT scan of the head. Then you can also do coagulation panel and platelets. What's the complication? Increased ICP, seizures, rebleeding, vasospasm, hydrocephalus, and SIADH. Now, what's the treatment? Admit to ICU. ABCs always, airway, breathing, circulation. BP reduction. Guys, when you're trying to reduce the blood pressure, it must be gradual. Okay, so what can we use, doctors? We can use nicardipine, we can use labetalol, nitroprusside, and others. But the point here is this: the BP reduction must be gradual. So, initial management of elevated intracranial pressure. What's the first thing that you need to do? Before giving meds, elevate the head of the bed to 30 degrees, semi-Fowler's, okay? Before giving any meds, try that one. If if on your answer choices you have medications and you have that, try that one first. If the question is asking the initial management, elevate the head of the bed to 30 degrees. Then you can give your medications. What are they? Mannitol, high yield. It's an osmotic diuretic. It is often used to lower intracranial pressure. You can also give barbiturates. You can also give CSF, neuromuscular blockade, and CSF drainage. If the patient is on anticoagulation or antiplatelet agent, you need to give vitamin K for warfarin, right? High yield. Vitamin K, antagonist for your heparin. Prothrombin sulfate is the antagonist for your heparin. Prothrombin complex concentrate for warfarin and your newer oral anticoagulants. Actually, for warfarin, the best antagonist for warfarin, in the answer choice, it should be prothrombin complex concentrate. Why? So you have vitamin K and prothrombin complex concentrate in the answer for antagonist to warfarin. The correct answer is prothrombin complex concentrate. Why? Why do you think? That's the correct answer. In a patient who has like overdose of warfarin,
You want to
warfarin or warfarin skin necrosis, for example. The patient has a protein CNS deficiency. You have warfarin skin necrosis. You need to antagonize warfarin. In the answer choices, you have vitamin K and PCC, prothrombin complex concentrate. I want you to pick PCC, not vitamin K. My question is why? Anyone? Think about it.
Does it like resupply the factors that are gone?
Excellent. Good job, Raj. So prothrombin complex concentrate, that's the one that has all the clotting factors. If you give vitamin K, it takes a while for the body to produce your factors. But in prothrombin complex concentrate, it has all the coagulation factors in your cascade, right? So if they're both on the answer choices, pick PCC. Don't forget, don't give steroids. If someone is bleeding, the use of steroids, it is harmful and not recommended. Sometimes we need to do like bore therapy. We bore a hole on the brain. All right. Rapid surgical evacuation of cerebellar hematomas can be life-saving. However, surgery is not helpful in most cases of intracerebral hemorrhage. Now let's go to the fun part. All right. Subarachnoid hemorrhage. Let's go back to term 2, anatomy. Common sites of subarachnoid hemorrhage. Tell me the common signs, the 3 common signs. 1.
Headache.
Common sites, anatomy.
Anterior communicating artery.
Oh, okay, but where? Junction of anterior communicating artery with what? Anterior cerebral artery. 1. Next. Anatomy. Where's my anatomist?
And then turn carotid.
Yes, but the junction of the posterior cerebral artery with the internal carotid artery. Good. Last but not the least, see, they're both bifurcations, right? So lastly, you have the bifurcation of your MCA. So those are the 3 common sites of your subarachnoid hemorrhage. Summarize them all into one word: junction or bifurcation. That's it. So what are general characteristics? Guys, this is very deadly. 40% to 50% die at 30 days. Location, there's a very aneurysm occurring at bifurcations of arteries of the circle of Willis. True aneurysm or not? Or false aneurysm? What is Berry aneurysm? Can anyone explain it to me? Berry aneurysm? What is this?
It's an outpouching.
There's an outpouching, yes. There's a ballooning arising from a weakened area in the wall of a blood vessel in the brain, right? These are your saccular aneurysms. Most common form of cerebral aneurysm. Question then, what disease is associated with berry aneurysms?
There's,
Polycystic kidney, I believe.
Excellent, excellent. Autosomal dominant, autosomal recessive.
recessive.
ADPKD, autosomal dominant polycystic kidney disease with your berry aneurysms. So what are the causes then? Why am I having this subarachnoid hemorrhage? So first is a rupture of your saccular aneurysm. This high yield, this is the most common cause, right? Trauma is also a common cause, and arteriovenous malformation. Okay, I have a question, a clinical question for you guys, right? What can we do to a patient to rule out papilledema?
A lumbar puncture. To
Careful,
see if
careful, careful. So you do an ophthalmologic exam, right? To check papilledema if there's an increased intracranial pressure. If papilledema is present, can you perform a lumbar puncture? If there is a papilledema,
No,
why not?
the increased pressure.
What happens? Go ahead.
Herniation.
Excellent. You can have you may cause a herniation. So you don't want that. So if papilledema is present, high yield, do not perform a lumbar puncture. So what can we do then? If we can't do the lumbar puncture, repeat the CT scan. Okay? Repeat the CT scan. So what are the clinical features? They're gonna say in the vignette, the worst headache of my life. Sudden transient loss of consciousness. Retinal hemorrhages is also there, and meningeal irritation. How do we diagnose? Non-contrast CT scan. However, 10% of the patients, the CT scan may be negative. So if it is negative, the non-contrast CT scan is negative, you may perform a lumbar puncture. If your clinical suspicion is high. Lumbar puncture is diagnostic. So what can we see if we perform a lumbar puncture? There is no papilledema. The non-contrast CT scan is negative. Therefore, we perform a lumbar puncture. What can we see in the lumbar puncture? Blood in the CSF. This is a hallmark, high yield of your subarachnoid hemorrhage. Another one is a fancy term, xanthochromia, the yellow color of the CSF. Don't forget, this is the gold standard for the diagnosis of your subarachnoid hemorrhage. Read the question carefully, okay? Blood in the CSF, that's a hallmark, but that's not the diagnostic standard. What is the diagnostic standard? Xanthochromia, the yellow color of the CSF. It implies, so xanthochromia results from RBC lysis. It means then that blood has been in the CSF for several hours, and it is not due to a traumatic tap. Once you diagnose SAH, you order a cerebral angiogram. High yield, it is the definitive study for detecting the site of bleeding so that you can clip it afterwards. Give me the drug that we can give for subarachnoid hemorrhage to stop the bleeding.
Nifedipine.
What?
Nifedipine?
Nifedipine or nimodipine?
Nimodipine, sorry.
Excellent, excellent. So that's your nimodipine. Good job. Don't forget that one, guys. Okay. Now, complications, re-rupture, vasospasm, hydrocephalus, seizures, and SIADH. So how are we going to treat it?
Can you re-say the drug you said for that?
Nimodipine.
Oh, okay. Sorry. I see it on the slide now. I'm sorry.
Yeah, nimodipine. It's a dihydropyridine calcium channel blocker.
Okay, thank you.
Yes, no worries. So what's the treatment then? You know, you do minimally invasive, you know, such clipping. You can do like surgical, you can do medical, you can do bed rest, you know, stool softeners to avoid straining, because when you strain, you do the Valsalva maneuver, you increase intracranial pressure, and you increase the risk of re-rupture. You can also have analgesia for headache, IV fluids for hydration. Of course, we need to control the blood pressure. And nimodipine, there we go, it's there. Calcium channel blocker, nimodipine for vasospasm. It lowers the incidence of cerebral infarction by 1/3. Now, movement disorders, Parkinson's disease, right? What pathway is compromised in Parkinson's? The dopaminergic pathway, right? So if the dopaminergic pathway is compromised, what happens now to the activity of the cholinergic system? It is now unopposed. So I want you to think for Parkinson's disease, right? So from term 2, basal ganglia and your nigrostriatal region, they operate as a balanced system comprising of your dopaminergic system and the cholinergic system. Now, in Parkinson's, you have a deficit in the dopaminergic pathway. It is compromised. Therefore, the cholinergic system operates unopposed. So I want you to think now, what is the goal of treatment? The goal of treatment is either you enhance dopamine's influence, right? So that they can be like balanced, or you inhibit acetylcholine's influence. Okay, I want you to think Parkinson's disease in that template. Now, let's begin. What are the general characteristics of Parkinson's? It is a clinical diagnosis. Remember the trap mnemonic? Who can tell me the trap mnemonic?
Tremor, rigidity,
Rigidity, akathisia, and you have your
postural instability,
postural instability. Excellent. Good job, guys. Oh, okay. Now, guys, I have a question for you. Did you talk about palsy? Progressive supranuclear palsy, PSP? No?
No.
Okay. So maybe this is for step 2, but how are we going to differentiate Parkinson from PSP? Basically, PSP, or progressive supranuclear palsy, is a degeneration of the brainstem, basal ganglia, and cerebellum, commonly seen in middle-aged and elderly men. So like Parkinson's, you also have bradykinesia, you have limb rigidity, you have the cognitive decline, the whole shebang. However, unlike Parkinson's, you do not have tremors and you don't have ophthalmoplegia. That's it, basically, all right? So clinical features: pale rolling tremor at rest worsens with emotional stress. So the tremor goes away when performing routine tasks. Like the finger to nose, it goes away. When you do the finger to nose test, the tremor goes away. Contrast that one with essential tremor where it worsens. Bradykinesia, rigidity, cogwheel rigidity, poor postural reflexes, masked facies, dysarthria, dysphagia, and all of those types. Question. Blank is a key neuronal findings in the brains of patients with Parkinson's disease. What can we see histologically in the brain of people who has Parkinson's disease?
diminished substantia nigra,
In terms of
Alpha-succinate.
neuronal bodies. Neuronal bodies. That's my clue. Bodies. Okay, another clue. Hyaline inclusion bodies. What do you call those? Guys, don't forget Lewy bodies.
yeah,
Or neuron or hyaline inclusion bodies, they are a key neuronal findings in the brains of patients with Parkinson's disease. Okay, high yield, please. Don't forget that. And the clinical feature of Parkinson's, we have the mnemonic trap: tremor, rigidity, akinesia or akathisia, and then postural instability. How are we going to treat Parkinson's? Is there a treatment? No cure, unfortunately, right? So the goal is to delay the progression. So what can we give? High yield: carbidopa, levodopa, or Sinemet, right? It is the most effective of all the anti-Parkinsonial drugs. However, It can, if the patient is taking Sinemet for 5 to 7 years, you can have dyskinesia. These are your involuntary, often choreic movement, right? You can also have some GI effects. So high yield, don't forget, levodopa has an on and off phenomenon over the course of the day during treatment, which leads to a fluctuation in your symptoms. This is due to a dose-response relationship, and it often occurs in advanced disease. High yield, question guys. Medications that cause Parkinsonian-like side effects for pharmacology.
First generation antipsychotics like Haldol.
Excellent, good job. So you have neuroleptic drugs. You can have chlorpromazine, haloperidol, perfenazine. What else? D2, dopamine antagonist, metoclopramide. Don't forget that. And VMAT inhibitor, reserpine also. These are medications that causes Parkinsonian side effect. Okay, I have a clinical question for you guys. Which has a better prognosis? A patient with tremor or a patient that has bradykinesia as a predominant finding? So you have a Parkinson's, right? Which patient has a better prognosis? Patient with tremor or bradykinesia? What do you think?
Tremor?
Tremor, because we can control that one. So patients with tremor, high yield, don't forget, as a major symptom of Parkinson's, they have a better prognosis than those who have bradykinesia as a predominant finding. What else can we give? Aside from levodopa, carbidopa, bromocriptine, pramipexole, which controls symptoms. Pramipexole is the most commonly used. High yield selegiline, MAO-B activity, right? It inhibits MAO-B and reduces metabolism of levodopa. You can also give amantadine, don't forget, for early or mild disease. And also anticholinergic drugs, trihexyphenidyl and benztropine. You can also give amitriptyline. Why? Because it is both anticholinergic and antidepressant. And if worse comes to worse, as a last resort, after all of those drugs, the patient is still refractory. What can we do? Deep brain stimulation. Okay, if the patient is refractory to all the medications, or in patients who develop severe disease before age 40 years old. Now let's talk about Huntington disease, or chorea. AD, autosomal dominant. Onset is 30, 50 years of age. What is lost here? GABA, producing neurons in the striatum. Clinical features: chorea, altered behavior, impaired mentation, gait, unsteady and irregular, and incontinence. Give me a disease, doctors, in a young patient with movement disorders. Always keep this disease in a young patient with movement. Remember, Huntington, the onset is like 30 to 50.
Like Duchenne muscular dystrophy?
Duchenne muscular dystrophy, movement disorder. I don't think so. Friedreich ataxia. No, I'm thinking about
Wilson's.
What? Come again?
Wilson's.
Excellent. Good
Wilson's
job.
disease.
Wilson's disease. Yes. What is Wilson's disease? Wilson's disease.
They can excrete
Copper.
copper.
Excess copper. What's the mutation?
So it builds up in the basal ganglia.
Exactly. That's why you have movement disorders. What's the mutation? ATP7B, right? Wilson's disease is the mutation in the gene ATP7B. How about ATP7A mutation? What is ATP7A mutation?
That's
Kinky hair.
Menkes.
Collagen synthesis. Excellent. Good job. It's Menkes. You're ready for step 1. Okay. Always keep that in your differential, guys. Wilson's disease in a young patient with movement disorders. How are we going to diagnose them? Huntington's, MRI. What can we see in the MRI? High yield atrophy of the head of the caudate nuclei. You can also do DNA testing. What's the treatment? Unfortunately, there is no curative treatment. Dopamine blockers, they can help in psychosis, and they can improve the chorioathetoid movement. You can also give them antidepressants. Why? Because it coexists with depression. They have Huntington's chorea. And the most common cause of death for patients who has Huntington's chorea is suicide. You have an increased risk for suicide. All right. Tremors. I want you just to look at this table here. How can we differentiate Parkinsonian from cerebellar and essential tremors? So, Parkinsonian, resting tremor. Describe it. Pill rolling. Associated with rigidity, bradykinesia, shuffling gait. Improved by action. Cerebellar tremor. What's the description for this? It's a coarse tremor. You only see this one with action. That's why it's called an intention tremor. Associated with ataxia and nystagmus dysarthria. Remember, there's no tremor at rest. So when you do finger to nose test, you are worsening the tremor in a cerebellar tremors. Okay, that's why it's called intention tremor. Essential tremor, on the other hand, is with certain postures. For example, if your arms are outstretched like that, and then they started the tremor, you can see the tremors. Or certain tasks, when they're writing something, their hands are having tremors. So these are called fine tremors, associated with head tremor, vocal tremorlessness, and what a surprise, improved by alcohol. Okay, if you see in the vignette, the tremor is improved by alcohol. Think about your essential tremors. High yield, guys. Know this table. Right, so we just summarized that one, and we're gonna, is there an association between essential tremors and Parkinson's? No, there is no association between essential tremors and Parkinson's disease. So please know this table. That's high yield. Okay, next, ataxia. What do we mean by ataxia? Gait instability, loss of balance, impaired limb coordination. High yield, what are the causes of ataxia? Alcohol, of course. B12 or thiamine deficiency, cerebellar infarction or neoplasm, demyelinating disease like MS and AIDS, and tertiary syphilis, tabes dorsalis. Question, what tract is affected in tabes dorsalis? For tertiary syphilis, right? Tabes dorsalis, what tract is affected? DMCL, dorsal column medial lemniscus tract. Contrast that one with vitamin B12 deficiency, with your subacute combined degeneration. What is affected there? DMCL plus what? Corticospinal, your lateral corticospinal tract. Also, don't forget inherited causes like your Friedreich ataxia, autosomal recessive. In the vignette, they're going to say ataxia, nystagmus, impaired vibratory sense and proprioception. And of course, ataxia, telangiectasia, autosomal recessive, similar to Friedreich ataxia. What's the differentiating factor then if they're similar? You have telangiectasia. Question, what are telangiectasias? Can you describe it to me? Telangiectasia. These are, you have a widened venules. Your venules, they are like thread-like red lines. They have a red line pattern on the skin, right? Because the venules are widened. They are called like spider veins sometimes because they're like fine, they have a web-like appearance. However, it's not treatable when you have telangiectasia. Okay, there's no cure for telangiectasia. Dementia. So dementia, what's the general characteristic? It is progressive deterioration of intellectual function, characterized by high yield. There is a preservation of consciousness. You don't lose consciousness in a demented patient, okay? Consciousness is there. The most important risk factor, high yield, increasing age, okay? I have a question for you guys. Is it acceptable when you age, right, like I am, I'm getting older, some degree of memory loss, is that expected?
Yes.
Yeah, right? So it may be difficult for us to distinguish whether is this normal aging, is there a dementia due to normal aging, like a benign forgetfulness of elderly patients, from true dementia. My question to you, doctors, how can we differentiate then between true dementia and benign forgetfulness?
Is it that they're not oriented to like time and place, or?
And remember, in dementia, there's a preservation of consciousness. You don't lose consciousness in dementia. However, benign forgetfulness, it doesn't affect the normal day-to-day living or the baseline functioning of the patient. Okay, in the vignette, if it says, oh, my mother used to do this, but now she's not, think, oh, this is not benign forgetfulness. This is dementia, right? However, guys, benign forgetfulness is a risk factor for developing Alzheimer's disease. Okay, careful. How are we then do like differential diagnosis of dementia? There are different diseases that can cause dementia. So primary Alzheimer's, of course, high yield, 66% of all cases of dementia is Alzheimer's. You can also do vascular dementia or multi-infarct dementia. Stepwise decline. Can someone explain to me what do you mean by stepwise decline? In the vignette, how can they describe that? They won't say stepwise decline, because if they use that phrase, you already know, you're talking about vascular dementia.
I think with every like infarct, you lose some capacity to do something, and then you recover and you're fine, and then you have another infarct, and then it goes down again.
So in the vignette, they're gonna say, my dad has a fall, and then after the fall, he improved. But then there's another fall after that, and there's no improvement. So we call that stepwise decline. They're gonna describe it to you in the vignette. They're not gonna say the word stepwise decline. Other causes of dementia, space-occupying lesions, brain tumor, NPH, dementia, gait disturbance, and urinary incontinence. You have a normal CSF pressure and dilated ventricles. Also dementia with Lewy bodies. What's the characteristic of sign and symptom of dementia with Lewy bodies? What kind of hallucinations?
Visual hallucinations.
Visual, there's L there. Think Lewy bodies, there's L. Dementia with Lewy bodies, visual hallucinations. Also frontotemporal dementia. Peak disease, it's clinically similar to Alzheimer's, but what's the difference? What's the difference?
Aggressive behavior, or?
And so you have personality changes, right? In Pick's disease before the onset of your dementia. Other neurologic conditions, MS, Parkinson's, yada, yada, yada. Infections also, HIV, neurosyphilis, cryptococcal, Creutzfeldt-Jakob, and PML. Now, guys, high yield for the causes of dementia. Tell me, doctors, reversible causes of dementia. Reversible causes of dementia. Can you think of any disease, right?
Wernicke's.
Come again, please.
Wernicke's.
Wernicke's, yes, yes, it is reversible. What else? Vitamin B12, think about the deficiencies like B9, folate, or thiamine deficiency. What else? Medications, right? It can cause dementia, yes. What else? What can cause dementia, especially in the elderly? Depression, Don't forget, sometimes it's called pseudo-dementia of the elderly because it's not dementia. They're actually depressed. Also, subdural hematoma is a potentially reversible causes. What else? Hypothyroidism, right? Okay, now tell me the irreversible causes of dementia. Irreversible causes of dementia. We talked about it. Parkinson's, Alzheimer's, what else? Multi-infarct, what else? HIV, what else? Someone said Wernicke's before for the reversible. Now, this one, irreversible, is Korsakoff syndrome. And PML, and then your Creutzfeldt-Jakob disease. It's all in there. How are we going to approach someone who has dementia? Patient history, and do a thorough job in your physical examination. We can also do laboratory and imaging studies. How are we going to treat? Avoid doses of medications with adverse effects, like glucocorticoids, especially in the elderly. Opiates, careful, respiratory depression, sedative hypnotics, anxiolytics, anticholinergics, and lithium. You treat the comorbid conditions, and you involve other parts of the health care team. Now let's look at Alzheimer's. Very common cause of death in the US. Risk factors, high yield, age. Okay, age. Family history, especially for early onset, and Down syndrome. Don't forget the chromosomes that are linked to Alzheimer's. 21, 14, 19, 21, 14, 19. What's the pathology involved in Alzheimer's? You have a quantity of senile plaques. You have a focal collections of dilated neuritic processes surrounding a central amyloid core. We call this one the amyloid B protein. You also have high-yield neurofibrillary tangles containing what? High-yield abnormal tau proteins. You can have neuronal loss and prominent atrophy. Don't forget, the most important risk factor for Alzheimer's disease is age. Patients with Alzheimer's have cerebral atrophy secondary to neuronal loss. So, as expected, if there is atrophy of the brain, what happens to the ventricles? They're going to be enlarged. So, you expect ventriculomegaly. What are the clinical features of Alzheimer's? Benign. There are different stages, early stages, mild forgetfulness. Then the memory is progressively impaired. Then they need assistance for activities of daily living and complete debilitation and dependence of others, not for death. How are we going to diagnose Alzheimer's? Don't forget, just like Parkinson's, it's a clinical diagnosis. You exclude other causes first. CT scan or MRI shows diffuse cortical atrophy. I have a question for you guys. Give me like a treatment that is associated with lowering the risk of developing Alzheimer's disease, especially in women. According to research, this therapy is associated with a lower risk of developing Alzheimer's disease. Does anyone know? Hello?
Is it breast therapy? I'm not sure.
A hormone replacement. So your HRTs, your hormone replacement therapy, don't forget that. It is associated with lower risk of developing Alzheimer's. How are we going to treat Alzheimer's? Cholinesterase inhibitors, don't forget, avoid anticholinergic medications, right? So you can give donepezil, ribastigmine, and galantamine. They are the first line agents. Guys, the ginkgo biloba, all of those crap, they have not been proven to be beneficial. Vitamin E can be tried in mild to moderate dementia. In one study, a mega doses of vitamin E, like 2,000 internal units per day, it slowed disease progression and preserved function in people with moderately severe Alzheimer's disease. And for adjunct therapy, you give memantine. So don't forget that patients with Alzheimer's, they have decreased acetylcholine synthesis and they have impaired cortical cholinergic function. Therefore, cholinesterase inhibitors, they increase cholinergic transmission by inhibiting cholinesterase. That's why you give cholinesterase inhibitors to patients who have Alzheimer's disease. Now, dementia with Lewy bodies, right? How are we going to contrast this one with Alzheimer's and Parkinson's? Progression is rapid than Alzheimer's. High yield L Lewy bodies, visual L hallucinations predominate. You can also have extrapyramidal features and fluctuating mental status. Treatment is similar to Alzheimer's with neuroleptic agents. High yield selegiline, your MAO-B inhibitor, it may slow the progression of the disease, right? So, guys, doctors, your anticholinesterase medications like your donepezil, rivastigmine, they are only indicated, your acetylcholinesterase inhibitors, they are only indicated for Alzheimer's dementia and Lewy body dementia. That's it. No specific therapy for other causes of dementia. So you only give them in Alzheimer's and Lewy body dementia. High yield also delirium. How are we going to differentiate delirium from dementia? Which one is acute? Delirium is acute. So this is a mnemonic. Move stupid, metabolic disorders, oxygen, vascular, endocrine. These are your causes of delirium. They are high yield. So delirium is characterized by acute period of cognitive dysfunction due to a medical disturbance. So let's compare and contrast. The high yield point here is compare and contrast delirium versus dementia. Okay, doctors, causes of delirium. Could you tell me some causes of delirium? Acute cognitive surgery, medical conditions, we can say that, yeah. Medical conditions like stroke, heart disease, seizures, hepatic and renal disorders. What else? Remember, acute.
Psychiatric.
Psychiatric, let's say post, well, I'm much more
Uremia.
Come again, please.
Uremia.
Uremia, of course. Infections like UTI, systemic infections. What else? Medications. Remember, acute, right? Medications, narcotics, benzos. What else?
Dehydration.
Excellent. Electrolyte imbalances. And of course, it's Friday. We're going to the bar. Alcoholism, right? Don't forget that one. How about dementia? Causes of dementia, as I've said, Alzheimer's, multi-infarct, and Pick's disease. In delirium, what happens to the level of consciousness? Is it preserved or not? In delirium, is the level of consciousness preserved or not?
Preserved.
LOC. In delirium, careful, is the level of consciousness preserved or not?
Oh, no, it's not preserved.
No. How are we going to describe the level of consciousness? They're going to say in the vignette, altered level of consciousness or fluctuating level of consciousness. Another differentiating factor, doctors. Do you have hallucination in delirium or dementia? Hallucination. Where can we find hallucination typically? In a person with delirium or dementia? Delirium, excellent. Bonus points, what kind of hallucination?
Visual.
Excellent. Visual hallucinations. So, in delirium, what's the course? They're going to say in the vignette, waxing and waning, or worsening at night. So we call this one the sundowning. Right? In dementia, it is a progressive, right? Another differentiating factor, delirium is almost always reversible, and dementia is typically irreversible. How are we going to diagnose delirium? Use the CAM, confusion assessment method. Treatment, of course, treat the underlying cause. Delirium precautions. You frequently reorient. The patient, familiar objects and faces, family at the bedside. You maintain a normal sleep-wake cycle with blinds open during the day and correcting sensory impairments, like hearing aids or glasses. Guys, you need to avoid restraints and pharmacologic management of agitation as much as possible. However, if the patient is agitated, if the patient is trying to harm other people or the staff, what can we give? First generation antipsychotics. Say it. First
Haloperidol.
generation. Haloperidol, of course, if absolutely necessary. That's a caveat. Antipsychotics like Haldol may be used. Right. Coma. Did you discuss this? Coma. Depressed level of consciousness. So the patient is completely unresponsive to any stimuli. What's the approach? Assess vital signs, of course. ABCs, always. High yield. How are we going to assess a patient that is comatose? What can we see?
Don't use the scale, the Glasgow scale.
Okay, the Glasgow Coma Scale, that's high yield also. What are the three features of your Glasgow Coma Scale? EMV, right? EMV. Eye opening, motor response, and verbal response. Highest score for eye opening, 4. Motor response, 6. Verbal response, 5. Now, guys, how are we going to assess the cause of coma? Okay, I'm going to give you an example. Pinpoint pupil. The patient is comatose, you see pinpoint pupil. What's the cause of the coma? Likely, most likely cause of the coma. Pinpoint pupils.
And the pons.
They are constricted. The cause, give me like etiology. Is it due to alcohol? Is it due to infection?
Opioids.
Excellent. Good job, good job, good job. So it's narcotics, right? Pinpoint pupil, think narcotics is the cause of coma. Also, intracerebral hemorrhage, your hematomas, right? Okay, another one. You know this from term 2. Unilateral fixed dilated pupil. There's a herniation. But what nerve is compressed? What cranial nerve is compressed? You have a unilateral fixed dilated pupil.
Cranial nerve 3.
Oh, excellent. Of course, it's cranial nerve 3, right? Bilateral fixed dilated pupil. Let's see, bonus points.
Isn't that like your medulla or something, like the MFL or something?
No, etiology, Raj. Etiology. Is it due to what? HSV infection, TB, etiology. So typically for this one, absence of oxygen. This is like anoxia. Okay, don't forget that. Now, well, abnormal pupillary light reflex can be due to like hemorrhage or a mass or morphine, right, or anoxic encephalopathy or like use of recent eye drops. Okay, you can have that. Don't forget the Glasgow Coma Scale. How to rate. What's the highest score that you can get in your Glasgow Coma Scale? 15. Okay. So let's see here. We have that one here. So put a star there for the Glasgow Coma Scale. You have it there. We check the pupillary light reflex. We check eye movement, right? If the patient is breathing, it means the brainstem is functioning. You can do a lab test, toxicology, CT, and LP. Now, there is a syndrome, doctors, that mimics coma. Someone said it a couple of minutes ago. It mimics coma because the patients are completely paralyzed.
Locked-in syndrome?
Locked-in syndrome. Excellent. However, what is spared in locked-in syndrome? Yes, the muscles are paralyzed, but with sparing of what muscles?
The eye.
The eye, excellent. What? Vertical eye movement, right? Vertical eye movement. What else? Blinking and muscles of respiration, your phrenic nerve, right? Another differentiating factor is the patient is fully aware of their surroundings and they are capable of feeling pain, right? What is the most common cause of locked-in syndrome, etiology-wise?
Stroke.
Stroke. Where?
Anterior, inferior, cerebral artery.
Ica?
Basal Ganglia,
For
the
locked-in syndrome, I thought it's a basilar artery.
basal artery, yeah.
Basilar artery, right? It crosses, remember? So your pons. Ventral or dorsal? Ventral pons. That's like anatomy question. Don't worry about it. So this is usually caused by infarction to your ventral pons. How are we going to treat it then? So you correct the reversible causes. You give supplemental oxygen. If there's a narcotic overdose, you give naloxone. Dextrose if they are hypoglycemic. Don't forget, you give thiamine before glucose load to prevent hypoglycemia. And you identify and treat the herniation. This is important, I think, for ethics. Like, how are we diagnosing brain death, right? Irreversible absence of brain and brainstem function despite adequate oxygenation and ventilation. The core body temperature is more than 89.6. Don't forget, in most US states, if a patient is proven to be brain dead, the physician has the right to disconnect life support. The patient is legally dead. So for us doctors, however, the caveat, in most US states, check your local authorities, right? If a patient is proven to be brain dead, we have the right to disconnect the life support. Why? Because the patient is legally dead. However, you need to be sensitive and be considerate to the family. They must be informed and given a chance to say goodbye. Now here comes the tricky part. If the patient is in a vegetative state, the patient may have no hope of meaningful recovery, but there's a big but. They do not meet the brain death criteria. So that's a tricky one. If the patient is in a vegetative state, need to consult a lawyer then, or your ethics committee of the hospital. We're good so far? Yep. Let's continue. All right. So demyelinating disorders, MS, selective demyelination of CNS. What's the classical location of the plaque? Angle of the lateral ventricles. Don't forget that. Anatomy question. So there's a demyelination. So it involves what? The white matter of the brain and the spinal cords. What tracts are involved? Pyramidal cerebellar, MLF, medial longitudinal fasciculus for the lateral movement of your eyes, optic nerve, and your posterior columns. Women, in terms of etiology, they are 2 to 3 times more likely than men to have MS. I'm sorry, in terms of epidemiology, women are more likely than men to have MS. MS is what? Clinical diagnoses. So you have a combination of findings. You have a transient sensory deficits, fatigue, motor symptoms. These are your classic B symptoms. You have spasticity that can lead to weakness. However, high yield, the visual disturbances, optic neuritis, still gonna put this in the vignette. There's some monocular visual loss, pain during eye movement. Also, high yield internuclear ophthalmoplegia. This suggests diagnosis. Why do you have internuclear ophthalmoplegia? There's a lesion in the MLF, which results in ipsilateral medial rectus palsy on attempted lateral gaze, right? And horizontal nystagmus of the abducting eye. So CN6 then, lesion. Cerebellar involvement, you can have ataxia, intention tremor, loss of bladder control, autonomic involvement, neuropathic pain. But I want you to know optic neuritis and internuclear ophthalmoplegia. In terms of the course, typically present in their 20s to 30s. You have relapsing, remitting, the pattern of flares, relapse followed by full recovery. You also have secondary progressive MS and primary progressive MS. Diagnosis is clinical. So you can also order MRI and LP because you need to differentiate like MS if this is possible due to implications surrounding the management. High yield MRI is the most sensitive test and is diagnostic in the majority of cases. High yield, when you do LP and CSF analysis, you can see oligoclonal bands of what? High yield IgG, right? They are present in 90% of MS. So this is diagnostic also. So, guys, doctors, I have a question. Diagnostic tests for MS. Give me the 3 diagnostic tests for multiple sclerosis. 1.
MRI.
MRI. Why? MRI is always abnormal in 90% of MS patients, according to research. Next. Next.
CSF with spinal
CSF.
tap.
Good. LP. CSF. Why? It is abnormal in 90% of multiple sclerosis patients. Last one.
Clinical.
Clinically, it's in there, number 4. Look at number 4 on the slide. Evoke potentials. They are abnormal also in 90% of MS patients. Evoke potentials, it suggests demyelination of certain areas. So you are measuring the nerve conduction within the brain. So those are the 3 diagnostic tests for MS. MRI, CSF, evoke potentials. Okay? How are we going to treat high yield of acute attack? IV corticosteroids. You can also do plasma exchange, right? Disease-modifying therapy. There are many newer therapies. You can also give interferon, beta-1A, or glatiramer. Natalizumab also is a very effective infusion therapy. In terms of symptomatic therapy, baclofen or dantrolene for muscle spasticity. You can give carbamazepine or gabapentin for your neuropathic pain and treat depression for, if indicated. Is there a cure for MS? Unfortunately not. What are our goals then? 1. Prevent relapses. 2. You relieve the symptoms of acute exacerbations. Why are we giving IV steroids? IV steroids, they help hasten the recovery of the acute episodes in MS. However, they do not result in any improvement in long-term outcome. So you're just treating the acute episode. Good. Let's go to Guillain-Barre. Inflammatory demyelinating polyneuropathy. You have inflammation, you have demyelination, and the involvement of many nerves, polyneuropathy. Motor nerves, right? The most common form is GBS, high yield, usually preceded by a viral or mycoplasma infection. Common, Campylobacter jejuni, CMV, hepatitis, and HIV. I want you to focus on Campylobacter jejuni. May also occur in Hodgkin's, lupus, or HIV seroconversion. Clinical features, what's the high yield? Ascending weakness or paralysis of all 4 extremities. All right. Is this deadly? Yes. Why? Because if generalized paralysis is present, it can lead to respiratory arrest. Extremities may be painful. What's the prognosis for Guillain-Barre syndrome? So if they recover like within a month, it is a good prognosis. However, if they still have symptoms for like beyond 6 weeks, like a chronic relapsing course, the prognosis is less favorable. How are we going to diagnose Guillain-Barre high yield? CSF analysis. What can we see? Elevated protein. Another electrodiagnostic studies. You have a decreased motor nerve conduction velocity. What's the treatment? Monitor always ABC, airway, breathing, circulation. Monitor the pulmonary function. MECVENT may be necessary. Can we give IV immunoglobulin? Yes. Right? However, if the progression continues, you still have the ascending paralysis. right? It's threatening the phrenic nerve. You can do plasmapheresis. Do not give steroids. They are not helpful in Guillain-Barre syndrome. Let's summarize. How are we going to diagnose Guillain-Barre? A combination of the following: CSF fluid analysis, clinical findings, and nerve conduction velocities. Let's talk about neuromuscular diseases. Myasthenia gravis. It's an autoimmune disorder. You have autoantibodies against nicotinic acetylcholine receptors of your neuromuscular junction. So the peak incidence in women is age 20 to 30. So guys, don't forget, for Guillain-Barre, there's a rapid progression to respiratory failure. It can occur within hours. Therefore, diagnosis is critical. If you suspect it, immediately admit the patient to the hospital for monitoring. For MG, what can we see? Skeletal muscle weakness, ptosis, diplopia, and blurred vision. Don't forget, myasthenic crisis is a medical emergency that occurs in 15% of patients. How are we going to diagnose myasthenia gravis? What test? What do you call that test? Let's go back to term 2.
Hydrophonium.
What?
Hydrophonium.
Hydrophonium, excellent. The tantalum test. So, if they have MG, what happens if you give hydrophonium?
It restores it back.
Exactly. So you have temporary strength. Yeah. They regain their strength, right? However, if it worsens, what do you think is happening to the patient?
They have like Lambert-Eaton's instead of.
No, you're giving exogenous hydrophonium, and they worsen. Their muscle weakness worsens. We call this one myasthenic crisis, right? Due to what? Overdose of medication. That's it. Myasthenic crisis. How are we going to diagnose then? So you have a yield acetylcholine receptor antibody test. This is the test of choice. Okay? When you give you the list, this is it. This is the most specific. Now, someone said it, Lambert-Eaton myasthenic crisis. Myasthenic syndrome. So we need to contrast between them. Remember, LEMS, L-E-M-S, associated with small cell lung cancer. Don't forget, small cell lung cancer. Contrast this one with squamous cell lung cancer. What can we see in squamous cell lung cancer? Squamous cell. Come on.
PTH.
Excellent. PTH. There's something missing. RP, PTH related protein for that one. Good job. LEMS caused by autoantibodies against presynaptic calcium channels. So how are we going to distinguish LEMS from MG? The symptoms improve with repeated muscle stimulation in LEMS. Another high yield point, if you scan the thorax, you need to rule out thymoma, high yield. Thymoma is present in 10 to 15% of patients. And as I've said, you need to do hydrophonium test. Acetylcholinesterase medications cause marked improvement of symptoms. However, this test is not used anymore. Why? Because it has a high false positive rate, which limits its utility. Treatment, high yield. Acetylcholinesterase inhibitors, pyridostigmine specifically, duothymectomy, right? This is symptomatic relief. Give corticosteroids, azathioprine, and cyclosporine if they are not responsive to pyridostigmine. You can also give plasmapheresis. Why? To remove the antibodies to the acetylcholine receptors. IVIG, immunoglobulin, for acute exacerbations, right? Then, patients in myasthenic crisis, they have a low threshold for intubation, so do not wait until your patient is hypoxic. You need to monitor their forced vital capacities. Now, question, doctors. Medications that exacerbate the symptoms of myasthenia gravis. What are the medications that can exacerbate the symptoms of your myasthenia gravis? Antibiotics. I'm going to give you a clue. Antibiotics. Give me the class of antibiotic drugs.
Aminoglycosides.
Aminoglycosides. What else? Quinolones, fluoroquinolones, right? Beta blockers, of course. Antiarrhythmics. Class 1, 2, 3, 4. What class? Antiarrhythmics. Class 1. 1A, 1B, 1C. 1A. Example. Guys, quinidine, right? Your procainamide, right? Okay, please don't forget that. So those are the medications that exacerbate the symptoms of your myasthenia gravis. Antiarrhythmics, quinidine, procainamide, lidocaine, beta blockers, and your antibiotics like aminoglycosides and fluoroquinolones. Good job. Okay, DMD, Duchenne muscular dystrophy, from term 1. X-linked recessive in males. There is no inflammation here. What's the problem here? Dystrophin gene, right? It's gone. Dystrophin is absent, causing muscle cells to die. What are the clinical features? High-yield Gower's maneuver. The patient uses the hands to get up from the floor because of the weakness in the proximal lower extremity muscles. Another high-yield point, you can see enlarged calf muscles, pseudo-hypertrophy, as fat replaces muscle. High yield. How are we going to diagnose this? Elevated CK, creatinine, phosphokinase. However, DNA testing has now replaced muscle biopsy for diagnosis. Treatment. Prednisone, beneficial, right? Also surgery to correct progressive scoliosis. Question, doctors. Can you give me other hereditary disorders that can cause muscle weakness? Aside from your Becker, aside from Duchenne muscular dystrophy, can you give me other hereditary causes of muscle weakness? Let's go back to term 2.
Dystrophy.
Again, please.
Myotonia dystrophy.
Yeah, your ragged red muscle fibers. Yep. Don't remember from term 1 your mitochondrial disorders, right? They're associated with maternal inheritance. Don't forget your ragged red muscle fibers. Another one in term 2, autosomal recessive, muscle cramping after exercise, glycogen phosphorylase deficiency. What is this?
McArdle.
Excellent. McArdle's disease. Don't forget that, guys, okay? And then for Becker, less common than DMD, X-linked recessive. However, Becker has a later onset and less severe course. And don't forget the word for BMD and DMD, anticipation, right? Anticipation, meaning as the progeny expands, the onset and the severity increases. Okay, don't forget that word, anticipation. All right, let's go to neurocutaneous syndrome, NFT, right? Neurofibromatosis type 1, autosomal dominant. What can we see? Café au lait, high yield, neurofibroma, CNS tumors, iris hamartomas. These are your Lisch nodules. Complications, there's a lot. So don't forget, there are 2 types of neurofibromatosis. Both types have seizures, learning disability, short height, and macrocephaly. So what's the differentiating factor then from NF1 and NF2? NF2 is also autosomal dominant, but here in NF2 you have bilateral acoustic neuroma. That's a classic finding. They're gonna say in the vignette. So bilateral schwannoma for NF2. You have also café au lait and cataracts. So in patients with neurofibromatosis, the prognosis depends on the type and the number of tumors at their location. They can function really well. Yes, autosomal dominant. You have cognitive impairment, epilepsy, skin lesions. However, high yield here is retinal hamartomas and renal angiomyolipomas. You can also see rhabdomyomas of the heart, but that's pretty rare. So in the vignette, they're gonna put this hamartoma, angiomyolipoma, and rhabdomyomas. For Sturge-Weber syndrome, think capillary angiomatosis of the pia mater. They're gonna put a picture. They're gonna put port wine stain, right? So how are we going to treat this one? Treatment of epilepsy is often the mainstay of treatment. VHL, von Hippel-Lindau, autosomal dominant, hemangioma of the brainstem, right? VHL is hemangioma. Contrast that one with which one has the tuberous sclerosis, which has hamartoma, angiomyolipoma, and rhabdomyomas. VHL has hemangioma, angioma, and the cyst. High yield associated with RCC and pheochromocytoma. Right. Spinal cord. Syringomyelia from term 2. Most commonly associated with Arnold-Chiari. You have bilateral loss of pain and cape-like distribution. Diagnosed by MRI. Treatment depends on the size of the syrinx and whether you have Chiari. Malformation. Evaluate for neurosurgery is recommended. That's syringomyelia. Think about bilateral loss of pain. Why? Spinothalamic tract. And temperature sensation over the shoulders in a cape-like distribution. So your lateral spinothalamic tract involvement. Contrast that with your Brown-Séquard syndrome. What is this? Spinal cord hemisection, right? Commonly caused by trauma. What's the feature? High yield contralateral loss of pain and temperature, ipsilateral hemiparesis, and ipsilateral loss of position and vibration. Transverse myelitis, I've seen UWorld questions for this. So this is a rare condition that affects like the tracts across the horizontal aspect of the spinal cord, most commonly caused by viral infections. It has a rapid progression. Clinical features are there, just read them. MRI contrast is the imaging study of choice, and you can give high-dose steroid therapy. I've seen one question that the answer is transverse myelitis. Horner syndrome from term 2. What is this? Ptosis, meiosis, anhydrosis. That's it. Causes, mostly are idiopathic. If you have cervical spine injury, you can have this. Internal carotid dissection and Pancoast tumor, which is a pulmonary neoplasm of the superior sulcoseptal lung. Poliomyelitis. It affects the anterior horn cells, so mostly motor, right? Neurons of the spinal cord. The characteristics: asymmetric muscle weakness. The legs are involved, right? Think about who's the U.S. president that has polio? FDR, Franklin Delano Roosevelt. Absent deep tendon reflexes, you have flaccid atrophic muscles and normal sensation. The only U.S. president that won election thrice, because we don't yet have the amendment that bans president to run for 2 terms. So he's the only president that won 3 elections. Democrat. So bulbar involvement, you have cranial nerve 9 and cranial nerve 10. No treatment is available. However, we have vaccination for polio. Now let's look at seizures. So seizures, what are the causes? 4 M's and 4 I's. Please know them. Metabolic, mass lesions, and non-compliance with drugs, specifically anticonvulsants, and acute withdrawal from alcohol, benzos, and barbiturates. Highlight those. So if you're doing So doctors, if you're doing like H&P for your patient, you need to acquire a description of the seizure from the bystanders. What happened during the seizure? Is it a witness seizure? If it's witness, ask them, is there any loss of continence? What happens? Is there any tongue biting, right? Determine what is the baseline for the patient. Is the patient a known epileptic, right? Check the doses of anti-epileptics or any change in the medication. Check for injuries, head injury, fracture, right? Look for signs of increased ICP, and you perform a complete neurologic examination. Miscellaneous causes are your 4 I's: intoxication, infection, ischemia, and increased intracranial pressure. What are the types of epileptic seizures? You have partial seizure, subtypes: simple partial seizure, consciousness remains intact, high yield, contrasted with complex partial seizure where consciousness is impaired. So when partial seizure, they can evolve into generalized seizure. When this happens, we call this one like secondary generalization. It is important for you doctors to differentiate between absence, the petit mal, and complex partial seizures because their treatments are different. Okay? Absence seizures, high yield, they disappear in adulthood, whereas complex partial seizures do not disappear in adulthood. Okay? So that's why absence seizures is much more common in younger population, whereas complex partial seizures persist until adulthood. In terms of generalized seizure, you have a loss of consciousness. Tonic-clonic, grand mal, bilateral, symmetric seizure without any focal onset. You have a tonic, meaning the patient becomes rigid, right? Clonic, you have a muscular jerking of the limbs and body for at least 30 seconds. So they become rigid and sharp and they cease, right? That's why we call it tonic-clonic. Sometimes you have post-ictal confusion and drowsiness. So, doctors, how are we going then to do like a flow chart, like an epileptic seizure flow chart, right? How are we going to categorize them? So listen, epileptic seizures, right? Are they partial or generalized? Do they lose consciousness or there is no loss of consciousness? For partial, is consciousness impaired? If yes, it is complex partial seizure. What's the treatment? Phenytoin and carbamazepine. If consciousness is not impaired, it's simple partial seizure. What's the drug of choice? Phenytoin and carbamazepine. For generalized seizure, are they convulsions? Yes, then it's tonic-clonic or myoclonic seizure. What's the treatment? Phenytoin and carbamazepine. If there's no convulsion, absence seizure. What's the treatment? Ethosuximide and valproic acid. That's just like a summary of your epileptic seizure flowchart. One, absence. How are we going to diagnose? Right? First, you need to check anticonvulsant levels. Remember, one dose may be toxic for one patient and therapeutic for another. That's why we always check the dose. So if the patient's history is unclear, what can we do? CBC, electrolytes, blood glucose, EEG, of course, the most helpful diagnostic test in diagnosis of seizure disorder. CT scan of the head and MRI of the brain. Don't forget, MRI of the brain without gadolinium first. This is the more sensitive than a CT scan, okay? However, it's not always very practical. But if your patient is like unstable, right? So, doctors, what lab values are we going to check immediately in an unfamiliar seizing patient? You came in, the patient suddenly is seizing. So what laboratory values do we need to check immediately?
Calcium and potassium.
Calcium, excellent. What else? Sodium. Check sodium. What else?
Glucose.
Glucose. Excellent, right? And last but not the least, kidneys. BUN, blood, urea, nitrogen for your encephalopathies, right? Good job. So what's the treatment then? Again, ABCs always, doctors, airway, breathing, circulation. If they have a history, check non-compliance. That's the cause, almost always, with their therapy, right? Give a loading dose and continue the regular regimen. But please give a loading dose first. So they should be managed by a neurologist, right? And then if the seizures are controlled, you taper the medication, okay? There's something that's called a status epilepticus. So status epilepticus is like a prolonged, sustained unconsciousness with persistent convulsive activity. This is a medical emergency, doctors, commonly caused by compliance, poor compliance with meds, alcohol withdrawal, and neoplasm. So what are we going to give? What drug are we going to give in a patient who has status epilepticus?
Phenobarbital?
The first, no. We need to follow the.
Oh, benzos?
Okay, good. So you establish airway, then you give benzos, diazepam. What's next? Phenytoin, right? Phenytoin IV. And then, if they are resistant to that, the last one is phenobarbital. Okay, those are high yield. So benzos first, followed by phenytoin, and then phenobarbital. If the patient is having a first seizure, you need to consult neurology. You need to initiate anticonvulsant therapy. What are the agents? What are the drug of choice? Phenytoin and carbamazepine, right? Can you give anticonvulsants in a pregnant woman? Can you give anticonvulsant in a pregnant woman?
Depends on the anticonvulsant.
What?
Depends on the drug.
Most of them are teratogenic, right? So most of them are teratogenic, so please do a pregnancy test, okay, before prescribing. So phenytoin, carbamazepine, drugs of choice. You can also do the others. However, for petit mal absence, you give ethosuximide, high yield. How do we know that the patient has absence seizure, that the child has absence seizure?
They'll have the 3 hertz spike on EEG.
Someone is watching a sketch E. Good. What else? They're staring at you blankly. The teacher is going to say, this student is staring at me blankly for a couple of minutes every day. So that's a classical picture of absence seizure. Now, let's go to Lou Gehrig disease, famous baseball player. This is, you have, what's the hallmark for Lou Gehrig's? The presence of upper and lower motor neuron signs. That's your hallmark. Onset, 50 and 70. However, Lou Gehrig was very unusual. He developed this in his 30s, right? So initially, guys, don't forget, ALS can involve virtually any muscle. It can involve any muscle, but as the disease progresses, every region of the body becomes symmetrically involved, okay? So what's the clinical feature? You have both upper motor neuron and lower motor neuron signs. So tell me, doctors, the upper motor neuron signs. Let's go back to term 2.
Hyperreflexia.
Hyperreflexia, good. Spasticity, all right.
Positive Babinski.
Positive Babinski, excellent. How about lower motor neuron signs? The opposite then. Hyporeflexia, negative Babinski sign. All right, so clinical features for Lou Gehrig's. Don't forget progressive muscle weakness. Progressive. First noted in the legs or arms and then spreads to other muscle groups. There's no pain, there's no atrophy, right? You can see spasticity, and then you can see fasciculations, right? You can have dysphagia, You can have respiratory muscle weakness and all the others. How are we going to diagnose? There's no specific diagnostic test. However, we can confirm it via EMG. You need to do nerve conduction studies, okay? Or you could do like a clinical or electrical evidence. Treatment, there's no treatment, unfortunately, mainly supportive. However, high-yield riluzole, glutamate blocking agent, it may delay death by only 3 to 5 months though. But we have like a drug for this. Right, aphasia. Aphasia is loss or defect of language, commonly involving the dominant hemisphere, the left cerebral hemisphere. There are 4 types of aphasia: Wernicke's aphasia, Broca's aphasia, conduction aphasia, and global aphasia. So EMG and nerve conduction study. So EMG, it measures your contractile properties of your skeletal muscles. So if lower motor neurons lesion, they have fibrillations and fasciculations. Myopathy, meaning there's no electrical activity at rest. So demyelination, it decreases nerve conduction velocity, commonly seen in MS and Guillain-Barre syndrome. Repetitive stimulation causes fatigue in myasthenia gravis. What's the most common cause of aphasia? Stroke, high yield, is the most common cause. Okay, I have an anatomy question for you guys from term 2. In aphasia, right, the most common cause of aphasia is cerebral vascular disease. Let me check the time. We're gonna take a break in a couple of minutes, and we're gonna come back. So, most common cause is cerebral vascular disease. In aphasia, where speech is fluent, where do you think the lesion is? Anterior or posterior to the central sulcus? Speech is fluent.
Posterior.
Posterior, of course. Posterior to the central sulcus. Where speech is non-fluent, the lesion usually is anterior to your central sulcus. Now let's go to the nitty-gritty of this. Types of aphasia. Wernicke's, impaired comprehension of written or spoken language. Speech is grammatically correct and is fluid but does not make sense. Wernicke's, think word salad. It doesn't make sense, but the speech is grammatically correct. Broca's aphasia, in Spanish, like boca, the mouth, right? Broca, you cannot express your thought. Speech is slow and requires effort. For conduction aphasia, there's a disturbance in repetition, right? And global aphasia, both Broca and Wernicke's area in the brain, they're kaput, right? You have a disturbance in all areas of language: comprehension, speaking, reading, fluency. Wernicke's, word salad, there's a trouble in comprehension. Broca's aphasia, there's a trouble in speaking, right? It's non-fluent aphasia. Conduction aphasia, there's problem in repetition. And global aphasia, there's a problem in all areas of language function. How do we treat them? Speech therapy is most helpful. Bell's palsy, weakness, paralysis by cranial nerve 7 due to swelling of the cranial nerve. High yield, common cause, herpes simplex. Clinical features: acute onset of unilateral facial weakness, paralysis. Both upper and lower parts of the face are affected. Why? Both upper and lower parts of the face are affected.
Lower motor neurons.
There is no sparing of the upper part, right? For your facial nerve palsy or your facial nerve lesion. What's the diagnosis? Okay. Do not use steroids if Lyme is suspected. What can you give if Lyme is suspected? Doxycycline. Give tetracyclines, right? If Lyme is suspected, give that one. How are we going to treat it? It's not required, right? None is required. It's resolved. You can give like prednisone and cyclovir. This is in the hospital you give this one. This is what we're giving here. If someone has Bell's palsy, so prednisone and a cyclovir. They should wear eye patch, and then cranial nerve, surgical decompression of cranial nerve 7. Okay, doctors, give me differential diagnosis for facial nerve palsy. The patient comes in, you can see, oh, there's something wrong with the patient's face. It's a facial nerve palsy. Now, give me your diagnosis. What causes that facial nerve palsy? We talked about Lyme disease, yes, right? It causes Bell's palsy. What else? Trauma, right? What else?
Infarct.
Infarction. Think about mass lesion. Think about compressing, like tumors. Think about acoustic neuroma. Think about neurofibroma, neurofibromatosis, okay? Schwannomas. Think about Guillain-Barre syndrome, okay? The palsy is usually like bilateral for Guillain-Barre. And think about reactivation of your varicella, herpes zoster, okay? Those are your differential diagnoses for facial nerve palsy. All right, trigeminal neuralgia, tic douloureux, the most painful conditions known to mankind, truly. So, clinical features: brief, frequent attacks of severe, lancinating facial pain that involves the jaw, lips, and gums. So the ophthalmic division is less commonly affected. So basically, the V2, right, and V3 of your trigeminal nerve is affected. No motor or sensory paralysis. Diagnosis is a clinical diagnosis. You can also do an MRI to rule out a cerebellopontine angle tumor. High yield was the drug of choice. Carbamazepine for relieving the pain. You can also do like surgical decompression if medical therapy fails. SLE, your systemic lupus erythematosus. We're nearing the 2-hour mark, guys. Can we take a break for a minute, for a couple of minutes? Then we're gonna come back. Is that good? Or
Yeah.
how many minutes do you think?
30? 10?
30
However
minutes?
you need or would like.
Okay, let's get back like 8:30. Is that okay?
Is there
Yes.
any way we could do like the micro when we come back?
There is some, I don't know, I still have a lot of slides for pathology, huh? Let me check. 86. Do you want to do the micro part?
If that's okay with everyone, but I'm down for anything.
Yeah, we still have a couple of slides more. Yeah, I'm just finishing up the musculoskeletal, then the next one is infectious diseases.
Okay, perfect.
All right? All right, 8:30 then. Same link. I'm just gonna eat my dinner. All right. See you later.
Bye. Thank you.
Thank you.
No worries.